I put two talks together because each one of these topics in and of itself is probably a day-long conference, literally. Just Syringomyelia alone. I mean, you have some of the world's experts here. You're going to hear from Dr. Levy tomorrow. Dr. Matzdorf, who's, kind of, I think is the end-all, be-all in that disease. But also the controversies, because the controversies, I think most of what the questions are on the panels are controversies of, shrinking the tonsils, opening the dura, not opening the dura. What do you do with recurrences, scar tissue? What type of imaging do we use? All those things, I like to think of them more as, uses to treat as opposed to controversies, because the key to Chiari Syringomyelia is the individualization of the patient. There is no one size that fits all. And I think what we as physicians need to do a better job of is focusing on that individuality, understanding, listening to what symptoms are. And I think all of us can go over, if we look at our practices from 20 years ago, 10 years ago, 5 years ago, maybe even a year ago, they've changed and they've adopted. One of the things that used to never be thought of as a symptom of Chiari is memory loss, fatigue. Why is there so much controversy in Chiari? Well, let's go back to what a Chiari is. And, before I even go on in my slides, I can ask everybody here, and there'll be a little bit of a nuance of a difference. Yes, it's cerebellar descent, the tonsillar herniation, but what's the true definition? Is it 5 millimeters? Is it 3 millimeters? Is it obstruction of CSF flow? What's the difference between peds and adults? Are those definitions the same? And they're not. So you really can't just lump one definition or one terminology into one disease. There's so much variation. And I think one of the big factors is almost 1% of the population incidentally has Chiari. And it's even greater in patients that have some, again, where your definition is probably even higher than that. That's a lot of patients out there who are walking around with Chiaris and don't know that they even have one. So you can imagine if there's other symptoms that kind of are similar, headaches, pain, soreness in the neck, go on and on, ringing in the ears, an MRI's done, oh, you have a Chiari, that fits. So that's where there's a disconnect. And again, I will bear a lot of this on me and us as physicians, that we need to sit down and explain that, as opposed to just, it has nothing to do with that, and then move on and have the patient have to go to the internet to be their doctor. Symptoms often include headache, but people don't realize that there are 100 different diagnosed variants of headache, 100. So yes, Chiari has a classic type headache, and there are clearly variations in that headache, but there are 99 other subtypes that have nothing to do with Chiari. And again, peds versus adults is a whole nother topic. Robert Keating from Washington Hospital Children's, who unfortunately is not here and is sailing, did a great spearheaded a project bringing many of the faculty in this room today together to pool all of our adult and pediatric population. There's clearly a difference. They're not the same. And then treatment, who and what to treat. And that's what we're going to kind of get into a little bit. So let's talk about what constitutes a Chiari. And I think there's a common theme that most people that do a lot of Chiari, treat a lot of Chiari patients, whether it's medical or surgical, that number doesn't really mean all that much. Yes, you need some form of a definition. I think the radiologist needs something to determine whether there's a Chiari there or not. But someone with 10 millimeters of descent can be completely asymptomatic, whereas somebody with 4 millimeters and almost just crowding can be symptomatic. So the number in of itself, you have to take with a grain of salt. And again, common theme, you have to individualize it to the patient. Is there a syrinx? If there's a Chiari and a syrinx, yes, more than likely there's a relationship there. But what about low-lying cerebellar tonsils, a mid-thoracic syrinx? There's a history of trauma. Again, not everything is clear-cut. Cine flow, there's some discussion of this, where we measure with MRI the static components of the CSF flowing in that foramen magnum to see if there's flow. I think there's, Dr. Grant talked about this, I think there's some limited prognostic value in this as far as who's going to get better, who's not, but I think it does help with symptomatology, and I'm going to talk to you a little bit about that and how I use it in my practice. And then symptoms. Symptoms are the main thing, and not just symptoms of what you're saying, but an exam, a physical exam, a good physical exam, listening to the patient, really understanding where these symptoms are coming from, what's bringing them on, and distribution within the body, which is key. Anatomy doesn't lie. So that's why I think there's so much controversy. That's why we see so much controversy, because there are so many of these different variables. And it's very easy to, I have a torn meniscus. Okay, well, torn meniscus is a pretty defined anatomic consideration in cartilage. When you're talking about the brain and you're talking about all these other factors, it becomes a lot more confusing. So the most important thing really is, who do you recommend surgery to? That's a life-changing decision for the patient. And there has to be a lot of critical thought that goes into that. So not all patients with Chiari need surgery. That's first and foremost, and I cannot emphasize that enough. Because you're diagnosed with Chiari does not mean that you need surgery, and in fact, you should have surgery. Patient needs to be informed and part of that decision, because everything has a consequence. Every pro, there's a con, and vice versa. So you really have to make sure that your patients are part of that informed decision, and you're being very clear about everything, from how long you're going to be into the hospital, what types of complications. And one of the first things I tell my patients in the pre-op area is, I said, I'm going to tell you now, you're not going to sleep tonight. You're going to be up all night. You're going to be hearing bells and whistles, and nurses are going to be coming in and out. You're not going to sleep well. And those are things that patients they've never been in a hospital for the most part, or in an ICU. So really doing a really good informed, letting the patient know what the process is going to be, even small things. And again, correct diagnosis of symptoms is absolutely critical. So I want to kind of move along into some more meat of this, but the hallmark symptom of Chiari is pain, and pain is universal, right? We've all felt pain. Almost everybody's had a headache and has had some type of pain syndrome, whether it's a sore knee or a headache. But the key pain syndromes in Chiari are pretty defined. Headache is really the number one. It's usually what brings the patient to their doctor is a headache. Neck pain, girdle pain, arm, leg, in that order. And from kind of a meta-analysis of studies, these are the percentages. But overall, 70% of presenting symptoms for patients with Chiari are pain. So what are the non-related? Weakness is a big one, particularly in the hands. It can be the lower extremities, which will manifest as balance issues, being clumsy, but it usually will start in the hand, and that's usually where patients will notice it. Numbness, loss of temperature sensation, unsteadiness, double vision, difficulty swallowing. I think that's something that a lot of, it always amazes me, because when I see a patient, they've usually already seen a couple doctors, a neurologist, and nobody ever asks them about swallowing. And when you ask patients about swallowing, it's amazing how it's not, that check isn't there. But then when you ask, it's like, yeah, you know what, I do. And when did it start? About 6 months ago, a year ago, I thought it was just, I had a sore throat, and I thought it was just a vestige of that. So difficulty swallowing. Another big one is ringing in the ear. I mean, I'm guilty of this. I early on in my career, ringing, tinnitus doesn't have anything to do with it. And then you start to see over time that patients that have ringing in the ear after Chiari decompression, the ringing in the ear goes away. Not everybody, but a lot of patients. And then miscellaneous, dizziness, fainting, face numbness, hiccups, sweating, all of these things are variants. Signs, those are what we see as a physician and what you see and feel yourself. So nystagmus in the eyes, difficulty with gait, clumsy frequent falls, bumping into walls, negotiating turns. Hand atrophy is a big one, where you can look into the hands in what's called the thenar eminence, and you see that there's just wasting in your hands. And often it's one side more than the other. There's an asymmetry there. And then the sensory cape distribution, so you see that with the syrinx, you see that, I think that's more of a textbook thing. And again, I'm just speaking from my experience. I think I can't remember the last time I saw somebody with a true cape-like distribution like you see in the textbooks, and then fasciculations, where the muscles are kind of twitching. So one of the big ones of controversy is fatigue, depression, and memory loss. I think that a lot of times that gets blown off. That's not that. You're stressed out because you're sick, you're this, there's other things going on in your life. Well, we do have a better understanding of this now because of imaging. And they're real. There's no question about that. I would hope that nobody would ever say, oh, it's in your head, or you're making it up, or it's real, but what's causing it? What is the cause of this? And it is a constellation of things. And when there's a misdiagnosis or poor communication, that makes it worse. It's throwing gas on fire, because you're discounting something, we are discounting something that you actually feel and are suffering with. So education, understanding really helps reduce that you're not going crazy, that there is a process here, but we have to work together to figure out what's causing it. Surgery is not the first line. But we do now know through functional imaging, tractography, we can start to see active pathways and how the brain works in real time and see where these pathways are that we never really understood, because all we had before were cadavers and kind of anatomic models, animal models. But we now know that the cerebellum and the vermis, the midpoint of the posterior fossa and cerebellum, have a lot more role in memory, in memory, processing memory, abstract thinking, and it really is remarkable, and it starts to fit. Now it starts to make sense in some of these patients. So, you know, the saying, the devil's in the details. Again, headaches, there's over 100 variants. You've got to be very clear to define a headache that relates directly to a Chiari. There's controversy over if a surgeon, and I can poll everybody here, and I bet we're going to get maybe a 50-50. You know, do you operate on patients who just have headaches, completely neurologically intact, no other issues, just headaches? You know, you'll get different answers. And again, pain is common, but you're looking for patterns here. Diffuse pain, that's a much trickier thing. And again, it doesn't mean it's not real. What we have to look at is, if I'm going to do surgery, am I going to help you? You know, I don't want to just show you an MRI and say, look how great this MRI looks. You know, we want you to come back and say, wow, that pain's gone. So we look for patterns where it makes sense. Weakness as well really needs to be specific. This kind of diffuse general fatigue and all that, that's not really a weakness. You want to see something in a neurologic distribution. And if these symptoms don't correlate, you're going to have a really, really poor correlation of good outcomes, particularly longer term. And if this is another thing that I always get a lot of feedback from this, both from patients and some of my colleagues, but you know, if your first surgery does not help you, and there was some discussion on the panel yesterday about this, if you have a Chiari with the clear constellation of Chiari-like symptoms, and your symptoms in your first post-operative visit with your doctor, none of the symptoms are better, you really have to start thinking about the diagnosis. And everything may fit perfectly, but there should be some improvement. What improves first? Time frame, patterns, everybody's a little bit different. My experience, the headaches get better almost immediately. Someone was asking about a time frame. I usually see that in the ICU. That pressure is relieved almost immediately. But if every symptom is still there after the surgery, you have to start looking for other things. So here's some facts and thoughts. 30% of patients are completely asymptomatic that have Chiaris, significant Chiaris. No one dies of a Chiari, and I really want to stress this. And there's an asterisk on this. I mean, do people with Chiaris die from? Yes. People can get stung by a bee and die. People can, I mean, so in general, and I think you saw some data yesterday in some of the earlier talks, you know, death from Chiari and untreated, we're not talking about the surgery, is extremely, extremely, extremely rare. And that's something that I always like to tell my patients, because most people don't know what a Chiari is. They go get an MRI, their doctor calls them and says, oh, you have a Chiari malformation, you need to go see a neurosurgeon, click. Now you're trying to find a neurosurgeon, and then what are you doing? You're looking online. And so, you know, just kind of putting that in context, I think, is very, very important. And surgery is not a trial, it's permanent. This isn't a drug you try and you have a side effect and you stop it. You know, once that scalpel hits your skin, once that surgery's done, there's no going back. So that has to be a really a clear and informed decision, and it has to be together with your surgeon. And we choose treatments based on the condition, not on the symptom. Is it hydrocephalus? Is it the Chiari itself? Is it the syrinx? You have to treat what the problem is, not the symptoms. And again, we talked about the degree of clinical herniation. Yes, there is a correlation there, but it's absolutely not absolute. So you can't use that as a direct guideline. So the initial visit and kind of letting you in under our 10 of, you know, how do I think about things? And I'm speaking for myself and my practice. You know, first thing is who to offer surgery to. That's really the first decision point. Am I going to help this patient by offering them surgery? Who do I just need to follow and reassure? You're fine. Your headaches or migraines. We're going to treat the migraines. We're going to get you into the right hands for that. I'll see you back in a year. I'm here if you need me. Don't worry about this. We're going to follow you. And then here's the big one. Who to help? Who to actually help, because there are a constellation of symptoms. We don't have all the answers. That's a team. And that's something else I want to stress. There's no one doctor. And I know you all know how great we all communicate as physicians, right? Especially in the different subspecialties. We're constantly communicating when you come in. We never say, well, what did Dr. Smith say at your appointment, right? Yeah, so we know. And so that's where the help comes in. We're really helping to be that gatekeeper and get that team together. And then again, patient selection. You're picking the right patient for surgery. And what is the right patient? The patient that symptoms fit, that there's a high degree of certainty that they're going to have a good outcome from their surgery. And this is a team. It happens to be my team, but it's made up of a movement disorder neurologist, a cognitive neurologist, a neuropharmacist, Dr. Lester, who's speaking right after me, who's one of our neuropsychologists. She's one of two in our group who are phenomenal. It's a multidisciplinary team. So thoughts, again, mine. Adult and pediatrics are not the same. Age isn't a limitation. That's another big question. I think the oldest patient I operated on was 82. She went from being ataxic to a cane to a wheelchair. And she had a really significant Chiari Malformation. And, after surgery, she ambulatory-wise, she did great. So, again, every patient is different and unique. 1% of all MRIs are going to show an incidental Chiari. That's 3 million people walking out there with Chiaris that they don't even know about. So let's talk about, I want to go through some cases now. And I think that's really a great way to show real cases and kind of, you all can kind of help with the diagnosis and see what you think and kind of put a little bit in our shoes of how we look at things and how a workup is done. So this is a 25-year-old young woman who had severe neck pain, came to see me, complete lack of energy, debilitating headaches. Usually around her period, they get much, much worse. But even when she's not having her period, they're there. And it's pretty acute. This all happened over a few months. So she, her primary care doctor appropriately got an MRI. She has a Chiari. Very, I would say borderline, low-lying cerebellar tonsils, but fair diagnosis of Chiari on her MRI report. And she came to me thinking, I need surgery. I have all these symptoms. I looked at it. I have a headache. I'm tired. So again, sitting down and talking in the office visit, and that's where this is important, is when did this start happening? About 6 months ago. Before that, it wasn't really that bad. Anything new? Well, I started a new job. So I started a new job. I thought, part of it was that she really was not sleeping well. She was stressed out. She wasn't sleeping. Her neck on exam, it hurt. I said, does it hurt? Yes, right here. That's muscle. That's not Chiari. That's not nerve pain. That's muscle. That's muscle spasms. And she has a history of childhood migraines. She had them when she was a child. She had them later in high school, and then they went away. And it kind of is almost the same pattern coming back. Exams completely normal. I'm not helping this young woman by doing surgery on her. I'm going to make her MRI look better. All those symptoms are not related at this point in time. Now, is this something we're going to follow? Yes, we're going to follow it. But, her plan was her headaches resolved because she started back on migraine medications. She changed her sleep habits. The biggest thing she did was she changed her pillows because her neck that's where her pain was coming from. So she got a memory foam pillow, and that was it. That's a really good example of that. Now, let's switch gears. So this is a standing and sitting MRI. So we were talking about this, and I'm not going to delve too much into this, but yes, there are clear, and this has been pretty well shown, that on patients with MRIs, standing and sitting, and normal, even without Chiari, there are changes. There are changes anatomically. We also know, and some of you may, that have a Chiari that has not been treated, will feel headaches and pain and the neck pressure get better when they flex their neck. They're opening up that foramen magnum. That's why. And they'll put their pillows like this. It's not an uncommon thing where patients will tell you that. And that's because you're kind of opening that area up. This isn't a static thing. This isn't like a rock and a boulder. So there are prone, supine, sitting, standing, there are changes. So the question is, where does this fit into the decision process of surgery? And I think there probably are some roles in the variants. I can speak from my practice. Again, I think Dr. Grant talked about this. That's not something right off the bat that I'm going to change, but I do think it's going to become more common. And I do think it's something that we need to kind of stress to the insurance companies. This is a cine flow. So this is an actual, you can see the white is a cerebrospinal fluid. This is why this is helpful. Because when I see this, I don't know how I'm going to help this patient with surgery. They already have great flow going in front and back in that foramen magnum, in that opening. So my goal of surgery is to open that area up. If there's a robust flow there, I'm not sure that I'm going to help that patient. So this is where the cine flow really comes into play and helps. Now, sometimes this isn't on every patient. Sometimes it's really obvious where you don't see the CSF. I mean, there's 20 millimeters of descent. You don't need a cine flow. So let's talk about this patient, 42-year-old female, mild headaches, not really that bad, kind of downplaying them, dropping objects. She did start to know her husband was in the office and said, come on, be honest. And she's dropping her coffee mugs all the time. And so that was clearly a problem that she was having that was getting worse over probably almost a year period of time. Neck pain that was not really reproducible. It's kind of this deep pain that's in there that she couldn't really get to, and then was feeling unsteady on her feet. This is her MRI. So this is a pretty significant Chiari. I don't need a cine flow. Cine flow is not going to do much to help me here. I know there's obstruction. I know she has long track findings. Her symptoms completely correlate with this. So this, and then on her office visit, again, she did have ringing in her ears after questioning, now that you mention it. Difficulty swallowing and headaches are classic. Yes, when I lift, strain, have a bowel movement, lots of pressure in the back of the head. Everything fits. Check, 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 and check. I have a very good high degree of certainty that these symptoms are correlate, but more importantly, she's going to get better with surgery. And on her exam, she had atrophy, really, I would say, pretty weak, but bilateral in her hands with 3 out of 5 strength, decreased gag reflex, ataxia, and truncal ataxia, where her body was kind of shaking. So plan with surgery. So you go from this to this. And what is the surgery? The surgery is opening up that CSF flow. You see that white there. You see the CSF flow and pathway is now wide open. So I wanted just to kind of delve into the symptom aspects as well, because these things all tie together. And then you can kind of see where some of the questions that all of you have tie in, where some things fit for some people and not for other people. So where does hydrocephalus come into this? And this can be tricky. So things that we can see with Chiari are the hydrocephalus, which, it's a chicken and the egg. Is it the hydrocephalus that's causing the Chiari from a downward pressure, especially if it's a true hydrocephalus with pressure? Is the Chiari causing disruption of flow that's causing CSF pathway obstruction that's causing the hydrocephalus? Syrinx, same thing. Almost everything is flow related with Chiari. And think of it as a cork in a bottle. So this is a patient I did about 6 weeks ago. This is a young girl, 23 years old. She was going to donate plasma, and she passed out. And so that's not an uncommon thing, right? You're giving blood, you pass out. I don't think anything, no issues. Well, here's the problem. She passed out while she was just there with her friend. She didn't get her plasma taken yet. No one had really talked to her about it. And she was like, no, I do it all the time. It doesn't make me nervous. I don't get queasy. She just kind of dropped. So I didn't think much of it. And then she started having worsening positional headaches. When she was bending, when she was lying down, she would wake up with really severe headaches. Then she started to get double vision, particularly when she was driving, she really noticed it, and a stiff neck. So she got imaging, and so would you say Chiari or no Chiari? We have audience participation. Chiari, right? So, and I'm sorry, this is not fair because I have this little picture up here, but there's a Chiari. There's a significant Chiari. This is about, I think, 10 millimeters of descent. And again, I know I said not to use, but this is a classic. You can see, again, I don't need to see a cine flow study here. You can see the obstruction of flow. She's got pretty decent descent and drag on her medulla. Well, here's the thing. Look at the rest of her brain. Should this brain look like this in a 23-year-old? No. She clearly, by definition, radiographically, and that's important differentiation, radiographically has hydrocephalus. The question is, does she have hydrocephalus clinically? So how do I figure that out? So can I do a lumbar puncture? No. It would be great if I could, right? Because I measure her pressure. Pressure in the back's the same as the head. It's either high or low. We rule it in, rule out. No, I certainly can't do a lumbar puncture with that Chiari there. Really, the only other way to kind of measure that pressure is putting a catheter in the head. The other thing you can do is do the Chiari first, decompress that. Now, what's going to happen, I think Dr. Plotsky mentioned this yesterday in her talk, it's when you start to see continued CSF leaks after repair and they come back, you just have to start looking at that as being a CSF issue. Then the treatment is a shunt because it's just going to keep blowing out. It's like a water balloon filling up. And now you imagine here's a 23-year-old, and I want to put this in perspective because I think it helps see on our end. She was beyond frustrated because she went to an emergency room, a resident came down, was ready to book her for Chiari surgery. Oh my God, I got a Chiari here. Really didn't talk to the attendings or anything. That was a plan, we're gonna do surgery. Then all of a sudden, like, oh no, we talked about we're not gonna do surgery, we're gonna do this. Then it was like, you need a shunt. Then they all decided you don't need a shunt, we're gonna follow it. Now meanwhile, our symptoms, so that kind of vortex, which I know a lot of you kind of feel, that's where this, none of those are wrong decisions, but it's kind of putting the patient in the middle of it. So what we ended up doing with this was, in the operating room, we were planning on a shunt, and we put the catheter in first. If that pressure was low, that's it, I'm not gonna do a shunt. I know the pressure's low, and then we were gonna proceed with the Chiari decompression. Pressure's high, I know what the problem is. Her opening pressure was about 30. So the CSF kind of shot out and almost hit the ceiling. The normal high is 20. And we saw her, I think, 6 weeks ago in the office, and literally every one of her symptoms went away. Now, interestingly, she has a syrinx. So I'll give you a follow-up next year on what her MRI looks like and her Chiari looks like with a shunt in now. So again, it shows, with hydrocephalus, all these different variants, you have to kind of pay attention to what the symptoms are. There has to be a realistic plan. So treatment, I'm not going to go too much into this, but I do want to show something really neat. And there were a couple questions about ultrasound. So the treatment, there's variations. There's good data on, I shouldn't say good. There's some guidelines of data of all the different options of what you can do. And again, I think, opening dura, shrinking tonsils, duroplasty, what you're using, individualized to the patient. There's, a lot of times there's different ways to do, and they can all be right. But the idea is to kind of open that bony opening, remove that, usually C1, sometimes you have to take C2 off that ring just to really get exposure, and then you see where that descent is. Now, one of the things in the question of ultrasound is using ultrasound in the operating room before you open that dura to see if there's CSF flow. So we started working with a company for something totally else, doing bypass surgeries to put clear cranioplasties in that you can ultrasound through. And so again, here's the cerebellar tonsils. The goal of surgery is I didn't do anything in color because I knew we were going to be right after lunch and I don't want to make anyone sick. So here's the cerebellar tonsils here. And you can see I personally shrink them. And there's a key differentiation. You don't cut them out. You don't remove them. You shrink them. It's called cautery. They're little kind of forceps, and there's electricity that goes through that generates heat. And you literally just kind of press them and hold them there for a few seconds, and they shrink up, and it opens a space there. So, well, what about after? If patients are having symptoms in the office, what do we normally do? MRI. Well, we can get a cine flow, but there could be webs there. So one of the things we started using was these clear cranioplasty little plates that go into that bony opening, and you can see they're clear. And what they allow you to do really well is put in ultrasound in the back of the patient's neck in the office with just a portable ultrasound. And these are real images. This is from a paper that's going to be coming out. And you can see beautifully because the low frequency ultrasound now is the quality of those studies, the ease of use is so much better. So now instead of having to tell a patient to get an MRI, wait for the MRI, have it inconclusive, we can see real live flow just by doing an ultrasound right in the office. So these are some advancements, and again, at the end of the day, there's either blockage there or there's not. I'm not going to get into too much of Syringomyelia because you've got incredible lectures. You're going to have more to come. But I do want to differentiate, again, 2 quick cases. The 71-year-old patient, I have to keep updating her age all the time. I started seeing her 15 years ago, definitely has a Chiari and a syrinx. And by all kind of, I think most people would agree that that's an indication for surgery. And she was symptomatic. I put in quotation. She had tingling in her feet, numbness in her hands she would get occasionally. But that was really it. And I did recommend surgery 15 years ago because of that syrinx. She was 56 at the time. She was like, I'm not having surgery. Okay, so again, not just goodbye, we're following it. Every year she comes. She's a sweet Italian woman, so she always brings me cookies and everything else, so I love seeing her. Haley, my PA, knows who she is. And every year, her MRI is completely unchanged. And again, she saved herself a surgery from me. So again, individualizing, and I was comfortable doing this because I trusted her. I knew if she was going to start to have progressive symptoms, she was going to let me know, and that was our deal. Last case I want to show you just that is with syrinx. I think there was a question yesterday too about syrinx, and I think I think it was misunderstood. Trauma can cause syrinx, particularly lower down in the mid-thoracic and lower thoracic area. It's a very different etiology than a Chiari, without Chiari, because the pathophysiology is very different. And Dr. Levy's going to talk about that in detail. But this is a patient that there's no Chiari decompression that's going to help. This is a patient who was in a very major motor vehicle accident, had a seatbelt injury. This is where his traumatic syrinx is from. It clearly was caused from this. And the burning pain, the dysesthesias, that's where the help part comes in, where you have to help the patient get pain relief and figure out the best option. Again, I'm going to not go too much into Syringomyelia because you're going to get some more great talks. Advice, my advice, you are your only proponent. You have to be a pain in the ass. Don't worry about being a pain in the ass. I mean, to a point, and we're not talking about being rude and, because that backfires when you're getting angry at people that are trying to help you, particularly people in the front line, people answering the phones, the nurse practitioner, the PA. But you have to be a pain in the ass. If you're not getting the answers and you're not getting what you need and things still aren't clear, you've got to push for that. Speak up. Don't be afraid, make your doctor explain things to you. More times than not, if you're asking for that and you're still not understanding, there's a disconnect there, and it's usually not on your end. That disconnect, I think, is telling. So make sure and say, I don't understand what you're saying. Explain what you're saying. Get a second opinion. I personally never take that as, it makes me feel better. I'm like, great. Okay. If someone comes back and they said the same thing I said, that's great. Your doctor should never be offended if you're asking for a second opinion. And I don't have a problem with the internet. I know a lot of patients always, I'm sorry I went on the internet. I'm like, no, that's great. It actually helps me because we can start at, with a foundation. What the thing to remember on my end and your end is that everything you see on the internet may not relate to you, specifically to you, to your issues, your problems, your symptoms. So it's kind of like, okay, well, I saw you saw this, but this is why this doesn't pertain to you. That's our job, is to explain those things. Or this is why this does pertain to you. So my treatment paradigm, symptoms first, MRI second, meaning the symptoms are more important than what the MRI shows. And there's an old adage in neurosurgery, you treat the patient, not the MRI or not the imaging. Early symptoms that are mild, I'm going to follow them closely with Chiari. It's not an acute disease. You're not going to wake up paralyzed. Nothing bad's going to happen in a day, a month, a week, a month. But it does need to be followed. Again, no symptoms, no signs, no surgery. I'm not going to even get into Chiari 0 because I'm just not going to get into that. So we're going to talk about real Chiaris. Any motor weakness, especially in the hands, balance issues, brainstem findings, syrinx, most people are going to recommend surgery. So the conclusions, symptoms of a Chiari are multifactorial. MRIs do not always correlate one way or the other with clinical symptoms. Chiari is an anatomic, treatable, and curable disease. But again, right patient choice, communication is essential. Be vocal. You're your strongest advocate. Thank you. Hopefully I didn't run too far over.